you go on steroids, and it can take as long as 2 years to wean you off the steroids, and they go by your sed rate. And so it's an autoimmune disease that causes a lot of muscle aches and pains, and your sed rate is elevated, and you have to go on this steroid taper, and you check it by the sed rate. You might only drop it a 0.5 milligram at a whack, so it can take up to 2 years to get off the steroids. So some people are on steroids for all sorts of different reasons, but it's purposely to decrease that inflammation, and in some cases it's appropriate, but you also have to remember that it's also going to stifle any other responses, so you have to be careful.
What about the inhalers?
So an inhaled steroid works at the surface. So the beauty of inhaled steroids is it works right at the cells instead of it being in the system. Right. So you know, even they have nasal corticosteroids, and rather than taking oral steroids, which is going to affect your blood pressure and affect your immune response, if you use them intranasally, it just affects them at the surface and causes, you know, decreases the inflammation of the site. So that's what's nice about, like Advair has some steroids in it. And that's, so you have a long-acting beta agonist to decrease that inflammation, and you have the steroids to keep any localized airway reaction from going on, to keep those airways open. All right? So, we know A stands for artery, V stands for venous, C stands for capillary. When you see a big one, it has to do with the alveolar. Big A has to do with the alveolar gas amount, and D has to do with dead space. So our lungs have a certain amount of dead space where nothing really is going on in there. P has to do with gas pressure. So PaO2 is our alveolar gas pressure of oxygen in the lungs. Right? When you look at a blood gas, you're looking at the pH, the PaO2, the PaCO2, all right? And so you're looking at the alveolar level. We're wondering what the gas exchange is. And that's why we do blood gases on people. We want to know what's going on. Are they metabolically acidotic, or are they respiratorily acidotic? All right, we want to know. Where is it being driven with? Sometimes people are mixed. It's a little bit of both. And that's what our blood gases tell us. So diffusion we talked about, that's when you have, diffusion is when you have an ion that moves from a level of higher concentration to a level of lower concentration. Okay, it's passive. And we talked about the fact that the O2 crosses over that alveolar capillary, and it goes to, there's a lower concentration of oxygen because all the oxygen's been distributed, and the blood that's coming back has CO2, right? So it's low oxygen levels. So that O2 is diffused across the membrane, it binds to the hemoglobin molecule, and what happens is the CO2 diffuses through the capillary membrane and gets expired. Perfusion has to do with blood moving through the circulatory system, whether it's at the lungs or anywhere else. So the difference between diffusion is gas exchange. Perfusion has to do with blood movement. I just don't want you to get the two confused. So, CO2, you have 5% in your venous blood, and when you combine that with plasma bicarbonate, you're 70%. And in combination with both that and plasma proteins, you've got about 25%. This just tells you your concentrations of CO2. So we talk about the gas exchange. So the oxygen is diffused over the alveolar capillary into the blood. The hemoglobin picks up that oxygen. The blood circulates out to the system and to the different organs. It releases the oxygen and it picks up CO2 to bring back to the lungs. Okay. When you have a shift, you'll see I'll show you like this bell curve. And when you shift to the right, that means that somebody's temp's gone up, your PCO2 has gone up, and your pH has gone down because they become acidic. Right. If you shift to the left, It means that their temp is low, their O2 level is high, their CO2 level will be low, and their pH is alkalic, so it's high. And so when you have a right shift, that means that you need less oxygen, and when you have a left shift and you're acidotic, you want more oxygen. So the pressures are going to change. So your affinity for oxygen when you're alkalotic is less, and your affinity for oxygen when you're acidotic is greater. That makes sense? It's just important to know when you're acidotic, you need more oxygen. When you're alkalotic, you need less oxygen. And your body's going to respond to try and restore balance. Pressure within the alveoli is higher than the pressure in capillary blood. We talked about O2 going out to the cells. When it's metabolized in the cells, what happens is you get CO2. That goes back up to the capillaries, it's transported out, and it's again transported to the expired. And I've already just told you all this. The effect of oxygen on CO2 is called the Haldane effect. It just means that the dissociation curve we talked about that happens with oxygen and CO2, all you need to know is that the effect is called the Haldane effect. It just has to do with our CO2 and O2 levels. If you ever hear it, oh, it just has to do with
What's it called again?
the Haldane effect. And this is just kind of shows you the change in pressures that occurs, you know. Obviously, we talked about the fact that diffusion happens, so your pulmonary artery pressure is lower, the O2 levels are lower, and the pulmonary vein pressure, your O2 levels are going to be higher, because that's the oxygen in the blood that's being brought out to be pumped out to the rest of the body. So you just have, you know, you're going to have waxes and wanes in those pressures, depending on where you are in the pulmonary arteries and in the lungs. The oxyhemoglobin dissociation curve is this S-shaped graph, and it just shows a line. You want to see the graph that we talked about shows the relationship they have between oxygen and CO2. And this shows you that linear graph, see? So the pink part means that you're alkalotic. The red part means that you're acidotic. So when you're alkalotic, all right, you have an increased affinity for, you have a left shift. Increased pH means you're alkalotic, which means that your PCO2 is low and your O2 level is high. In an acidotic patient, your PCO2 is high and your O2 level is low. So you have a right shift and a left shift. We already went through that. So what causes a shift to the left? Your pH becomes high, your CO2 drops. People that have hypothermia, you will see this with. Shift to the right, you're acidotic, you have less O2 uptake by the hemoglobin, and you have less O2 circulating within the system. Decrease pH, increase PCO2, increase CO2. And if your temp goes up, you're working harder. And people that get really sick and septic, that are driven by sepsis, will become acidotic. And so the effect of carbon dioxide on this curve is called the Bohr effect. When we have a patient that's septic, we're looking at their lactic acid. The lactic acid happens with somebody who's usually acidotic, either metabolically or respiratory. Lactic acid is going to be higher. It's a byproduct of the muscles. When you have, when somebody runs, in the first few minutes that they start running, they are using anaerobic metabolism instead of aerobic metabolism. anaerobic metabolism, you have an increase in your lactic acid. When somebody's in severe respiratory distress or is septic, they start going into anaerobic metabolism because they're in overdrive so much that they don't have enough oxygen for supply and demand. And that's why when somebody's really sick, I check a lactic acid to see how septic they are. And to know, it often will guide where I need to put them because I know how sick they are. Does that make sense? So ventilation perfusion relationships, how much comes in as to how much is absorbed. So what affects that? Gravity. When you go to higher levels, people get altitude sickness. It has to do with the fact that the way that that ventilation and perfusion is happening is altered. Exercise. You know, when we exercise, your VQ, your ventilation perfusion increases. When you are lying down, if you think about it, you have less gravity. So your ability to perfuse is greater, as long as you're not in heart failure, left-sided heart failure. And the other thing is a pulmonary embolus. If somebody has a pulmonary embolus, you have a portion of the lung that those arteries are blocked with a clot, and that part of the lung cannot perfuse because the ability for blood to perfuse through the circulation is closed off, just like having a heart attack, no different. If you have an infarct here, an infarct in your lungs, it's a lack of blood flow to a particular area of that particular organ. So the VQ scan actually looks at the ventilation perfusion and shows the area that's not getting perfused. It's not getting enough oxygen. So that's what a VQ scan is. We usually do CT scans on people, but if they have poor kidneys, you can't give them the dye, and that's when you use a VQ scan.
With a PE,
Yeah.
I mean, that's like a medical emergency, so.
It depends on how bad they are.
Okay. Because my
It
friend.
can be.
Yeah, my friend went to the hospital because we think it was maybe an anxiety attack or anaphylaxis, but she all of a sudden just had like severe, and her hands turned blue.
Because she was probably hyperventilating.
And but they thought she could have a PE.
And
But I'm just surprised, I was like, they didn't give her a CT scan, it was a couple hours after she got to the hospital, so.
They didn't CT her?
They did, but it was like three hours after.
Well, it depends on what was going on in
Yeah,
CT.
yeah,
But her O2 levels were probably
Yeah,
okay, and
they
that's
were
probably
fine.
why they weren't sweating,
okay.
all right? Because she was still perfusing enough
Mhm.
O2 that the stats were stable. You can have a PE, and like I said to you, the body's really good at compensating. The problem is that you don't want tissue death.
Okay.
So the rest of the lung may have been able to pick up enough of the burden that they were oxygenating them all, but what you were, worried about with the clot, you worry about infarct,
Okay.
tissue death. So what you want to do is you want to put them on blood thinner, number one, so they don't make any more clots, and number two, to dissolve that clot so that oxygen is restored to that area of the lung if you don't have any, you don't have pulmonary infarct.
Okay.
And then you have to worry about why did they have a pulmonary infarct? Did they have a DVT because they were on a plane for too long? Is it because they're morbidly obese and they don't move around? Did they just have big hip surgery where they could have shot a clot because they had big surgery? That's why when people have total hips or they put them on an anticoagulation for a short period of time. And some people are just, cancer patients are often more hypercoagulable. And they often will shoot a clot. So you have to kind of look at what caused it. Right? We always want to know why. Right?
I have a question.
Yes.
If a patient has PE, you wouldn't give them TPA, would you?
No,
Okay.
you don't give them TPA.
Okay.
The vessels are too small to be doing any of that kind of stuff, microvascular. So you're gonna put them on heparin.
Okay.
Or you're gonna put them on Xarelto, one of the NOACs. Heparin is, low molecular heparin is used if somebody has really bad kidneys and they have to go on Coumadin. Because it takes 5 days at least to get your Coumadin levels up where it's therapeutic. So you gotta bridge them in the meantime, where they often do heparin Q8 hours, or Lovenox, which is weight-based, twice a day. With Xarelto, or Pradaxa, or Eliquis, you can dose them, and you don't have to bridge them. Because they're at 50% effectivity within 12 hours, and within 24 hours they're at full anticoagulation. So the beauty of the new NOACs is that you can treat somebody right away, you don't have to bring them into the hospital because you don't have to bridge them, you don't have to worry about bridging them, and as long as they have decent kidney function, it's really wonderful. I mean, I only put people on Coumadin when I have to.
But isn't the downside to that if those patients have, if their blood get too thin, they don't have any?
Well, no, because it's not gonna get any thinner than it is, it's a whole different mechanism, it doesn't get any thinner, okay? Let me tell you the difference between Coumadin and the NOACs. Coumadin is very variable. Your kidney function affects it, your medications affect it, your diet affects it, there's so many variables. Your alcoholic, it affects it. I just had an alcoholic come in with a nosebleed and his INR was greater than 9. Okay, he's a drinker. You know, so there's a lot of oh yeah.
So you're telling me when I get old, I can just drink instead of taking my food?
No, then you'll end up with a liver that doesn't work. No, what it did is it potentiated the effect of the Coumadin, so that he ended up with a really bad bleed.
Yeah.
And has atrial fib because he has a boggy heart because of drinking. So he has atrial fibrillation, that's why he's on Coumadin.
Yeah.
And so he'll probably end up with a stroke if he has to stay off of Coumadin too long. We brought his INR down, gave him vitamin K and FFP to reverse it so that he wouldn't bleed out. But he was still oozing and has to stay off Coumadin for 2 weeks because we got to get his nose to clot and stop bleeding. And he could have a stroke in those 2 weeks because his INR is going to be subtherapeutic. So, with Xarelto, I had a woman who broke her hip. She's going to be operated on. We held her, she has normal kidney function. We held her Xarelto for 1 day. She'll be done the next day.
Wow, that's good.
Wow, really?
It only has to be held max 48 hours.
Wow.
And Coumadin, you can give them vitamin K and FFP, and I'm going to tell you something. Their INR doesn't come down much quicker. It really doesn't.
So why are so many people on, I have more people at my work on Coumadin than Xarelto.
Because the doctors haven't gone and educated themselves about it and don't use it that often, and they figure if it's not broken, they're not going to fix it.
It's insurance too though,
But-
because
No,
I
no, let me tell you about that.
I had a patient
No,
at
let
my
me tell
clinic,
you
hold
about
on, let me explain. I had a patient at my clinic, right?
Yeah.
And the doctor wanted to put them on Xarelto.
What kind of insurance did they have?
Some Mass Health,
Mass Health pays $3.
they would, no, that's what I'm saying. So
$3.
some of them who can't afford it, they would,
$3. Their copay's $3.
no, they wouldn't cover it.
Yeah,
They wouldn't cover it.
I'm going to tell you right now.
And they cover Coumadin, but they wouldn't cover the Xarelto.
I'm going to tell you right now that I deal with this day in and day out. If they have any insurance, all of the insurances are accepting it. Check and see if they can do Eliquis or one
Well,
of
it's
the other
cheaper
ones.
than paying for a stroke.
They will allow, they do allow it. It's a tier 2 drug. The only one that ends up in trouble are the people that have the donut hole, the Medicare patients that have that donut hole. That after they reach $2,500, it has to be out of pocket.
Oh,
They're the ones that end up in trouble. The
That's
poor
not good.
Medicare patients that have a donut hole are the people that have a problem. And I will tell you,
that's not fair.
Xarelto and Eliquis all have a no copay or a $10 copay thing.
That's amazing.
Trust me, I do this every day.
Do you need labs? Do you have to get?
No,
blood
no
drawn?
labs.
That's why it's,
No.
right,
No
that's why
labs.
it's cheaper. So
You don't have to
usually-
worry about if they go on something because they have a urinary tract infection. You
Yeah,
don't
but
have to
that's
worry
illegal.
about meds. Kidney function's the only
But
thing.
there's no reversal either for Eliquis or.
But it's out of your seat. You can operate on somebody within 12 hours. It's halfway.
Yeah.
So when you stop, basically when you stop taking the medication, you have 12, 24 hours and your
And they
coagulation
actually do-
is
they
normal.
actu- Yeah, we actually do have something that you can give them to reverse it. That's really not true. But usually you can wait 12 or 24 hours to do surgery. And so there is if you look at the site of action on these NOACs, there is something you can do. It's a PP something inhibitor that you can give them. And I will tell you that I believe it's this year that they're going to have a reversal agent anyways, because Pradaxa already has one, they have Pradaxa. But I actually use Xarelto and Eliquis the most. Eliquis
Well,
is easier on the kidneys.
It just seems so much more convenient.
It's not just convenient, but if you look at the studies, because you don't become under or over anticoagulated, you have less risk with serious bleeding, there's less mortality risk, and there's less risk with strokes because you're undercoagulated. Overall, people are better with it.
So people who are kidney impaired, you might be more likely to see them on Coumadin though
If their
because.
GFR is less than 15%,
Oh.
they have to go on Coumadin.
Okay.
If the GFR is 15 to 30, I adjust the dose. If
Right.
the GFR is 30 or greater, it's full dose.
So that's why when you're on long-term care floors and stuff, everyone's on Coumadin because
Because they have horrible
they're
kidney
shot.
failure too.
They're shot.
I had
Yeah.
a lot of patients on Xarelto too.
But
Yeah.
then you also have these paranoid old guys who sit in front of the TV all day and they're, I'm not doing Eliquis, it's Xarelto, that can kill you, I've seen it on TV. They're all
I
crazy
know,
like
well,
that.
but you know what? They're being fed rat poison and they're okay with that.
Right,
So
Coumadin.
what you need to do is you need to be well informed and you have to sit down and talk to the people about the studies. And I go to a lot of these drug dinners and I educate myself on new drugs. Yeah, well, that's what I did. You know, the educational dinners, and I mean, I'm actually educating my physicians about this. And the orthopedists are finally getting on board of using it post-surgery because it's so much easier, it's easier for the patients, it's much easier. Much, much easier. There's better compliance with it. You know, so you have to look at the patients that are gonna use it, and you have to tell them, if they go on Eliquis, or Xarelto, they can't miss a dose, because it acts quick, and goes away quick.
Right.
You need to be really good about dosing,
Oh.
all right? It's really important, because we don't have labs to check to see if they're, so it's really important to have somebody who's responsible to dose them, all right? With the Eliquis, you have a little wiggle room, so if you miss your second dose, because the Eliquis carries a little longer, you have less of a window where you're in trouble. So it's a little more user-friendly, and it's a little more kidney-friendly. So when I have people who have any kind of kidney disease, I usually use Eliquis. So, all right, we're way off the track.
That's cool, we're still learning.
All right, so, yeah, but it's important to know, because you see a lot of it, and I want you to know why we prescribe it, how we prescribe it, and what are the rationale for using it. If somebody has a mechanical valve, they can only be on Coumadin.
Why's that? See, now you're opening up another can.
Kinda
of
weird.
worms.
Because for mechanical valves, Coumadin is the only thing that is approved to keep from anything forming a problem with that mechanical valve. If they have a bioprosthetic valve, they can go on one of the novel anticoagulants. But none of these novel anticoagulants have been studied with patients who have mechanical valves. So they have to be on Coumadin and have to be bridged, because they can never be not anticoagulants.
Simply because they haven't studied it.
Yes, because
No.
they're not going to take a chance with somebody with a mechanical valve of causing them to have a big stroke. So they probably will never approve it for people that have valves.
Because they won't even be ballsy enough to start doing a study on it.
It'd be too
We just did
scary.
all this work, on this patient, all this stuff, there's all this liability, et cetera, et cetera.
You don't want to have them die because of the study, and the risk is, you have to look at risk and benefit, the risk is too great.
Right.
Risk is too great,
You'd have to find somebody to volunteer anyway.
yeah, risk is way too great.
I wouldn't.
You have
If
all-
somebody said to you, you have a mechanical valve, you cannot be not anticoagulated. Do you want to try a drug that we don't know if it'll keep your blood thin enough? You might have a massive stroke and then
Depends
it's
how much
drooling
money
and
they want to
dragging your
get.
left leg.
If I'm 90 and I just had the second one done, you know?
But none of you, you're not
But
gonna
90
do
might
it,
give
they're
them
not
a
gonna
chance on a
do the
90-year-old.
study anyway, all right? Because you're not
Because
gonna do
they're
a
not normal
valve on a
body,
90-year-old.
They
It'd be
offered
like
it
a
to my grandfather
60-year-old.
for the second time, he had it tightened and he was in such good shape that they went, you know what? It's loosening,
Well, there you go.
you know?
And I should take that back. I
They're
would say
starting
that
to do more to
generally,
old people.
you're not gonna see in a 90-year-old, but age is just a number. I have some 90-year-olds that can run circles around people. Like I said to you, I was out hiking with a woman who was 82, who was at the front of the pack. You would never know she was 82. She was she's just as fit, she's very healthy. I have some 60-year-olds that have one foot in the grave. So it's real,